Pastor, I understand this is the Pearly Gate Baptist Church, but I didn't know that meant you had a pearly handled microphone too. That's that's impressive, man. We know who's in charge down here. I would like to introduce. Boy, I'm not going to get everybody in Amgen's names. Let me just say, we're fortunate that we have representation from Amgen here. There's support for this program. If we get the members of Amgen who are here, please stand up so we can give you a hand or support. Thank you very, very much. And you'll be hearing more from them a little bit later. But as far as the HEAL Collaborative, program has been organized here locally by Ms. Shanika Bonds. And of course, Stan Watson's already been introduced, and Vice President of Community Affairs, we have Ms. Gabrielle Jones. So thank you all. I want to remind you that on your packets, you have a survey to fill out. There's the pre-survey, and at the end of the program, if you'd be so kind as to fill out the post-survey also. If you fill it out right, you'll be into a contest to take Howard Mosby home with you. He is paper trained. He can do a few odd jobs around the house. So he does have some value for you. With that, let me introduce our first speaker who's going to just welcome us here further. Is Mr. Howard Mosby. He is the former Georgia State Representative, and he's also current Corporate Treasurer for HEAL Collaborative. The Honorable Howard Mosby. Good morning. And I have to get Dr. Tuxton. Whenever you get the mic, you can say some stuff. So, but I'm gonna leave him alone. No, thank you all for coming out this morning. I want to thank Pastor Gillespie for inviting us into your home, sir. This is indeed an honor for us to be here and to support this community in bringing this important information. I also like to thank Amgen for their unwavering support of our organization and making sure that we do these things and bring this information to your community. How many of you seen pharmaceutical commercials talking about stuff like Ozempic or things of that nature? Well, those companies are not in your community. This one is. You get an opportunity to put your hands on actually this company that's putting this work behind that. So we wanted to bring that opportunity to you. Our organization, HEAL Collaborative, is really about bringing trusted subject matter experts and information to our community to make us healthy. And we do this city by city, community by community, because guess what? Our lives matter. And so health is one of the biggest differentiators in how communities actually improve themselves. And we want to make sure that we bring the right information to our community. So it is indeed our honor to be here today. I would like to thank my team for being here and doing the work that they do. Couldn't do this without them, and I just want to thank them publicly for this. With that, I would turn this back over to Dr. Tuxton. Thank you very much. Thank you for your time. We'd like to begin the next part of the program to kind of give us a glimpse into the reality of what it means to be a patient with small cell lung cancer. We do this little bit called a fireside chat. It's a real communication between folks. And we're going to be today, we're going to be hearing from Ms. Nicole Brown, who is a caregiver to her mother, Ms. Sheila Fields, who is a small cell lung cancer patient. And also from our moderator, though she's going to be more of a conversation with this, since there'll be the two of them up here right now, who is Ms. Montessa Lee. I'm going to try to bring in, since we're in Memphis, you can't come to Memphis without quoting from the canon of Stax. And within there was William Bell, who sang the song, "If you can't pay your rent, come on home with me, I'm your friend." And that is Ms. Lee. Ms. Lee is that friend who has channeled her experience as a small cell lung cancer patient to make life better for her friends known and for her friends unknown. She is a member of the Speakers Bureau of the Lung Cancer Foundation of America, and as I said, is a small cell lung cancer patient. So, Ms. Lee, why don't you come on up? And Ms. Brown, why don't you guys come on up also? No, yeah.
Thank you for joining me today. This lung cancer journey is quite interesting. I was diagnosed in 2006, and it's been quite a journey. So I know you're here and representing a caretaker for your mother. And I know that, you've had 2 bouts. So can you just tell us about your lung cancer journey with your mother?
Okay. Like at the end of 2018, she went to the ER for something. I don't even think it was had anything to do with her lungs. And they did an X-ray and they saw something, and they wanted to do a biopsy. And the doctor immediately, when he did it, he already knew that it was cancer. So they want her to go straight to an oncologist. And we went and he talked, with the family, like what did she want to do? He was going to treat it aggressively. And then she went in remission. And she stayed in remission for a long time. And then one of her scans, they saw a femoral spot on her liver and clavicle, but they was really, really small. So.
And can you tell us a little bit about, they had another scan. So when you have that initial diagnosis, I'm assuming she had to go back just like I did, and you have to get scans from time to time. Can you tell us a little bit about that experience for you?
Usually it's like, I think like every 3 months, go and do like a PET scan, and get a PET scan, and that's a little nerve wracking waiting on the results. But like I said, for a long time they came back clean.
Oh, good. Yep. And I had a similar experience in 2006. I had a cough that wouldn't go away, stabbing chest pain. Went to 2 doctors before they finally gave me an X-ray.
Mm-hmm.
And I describe it to people like this. That night in the ER, I was on my way to my grad school class to take I was in my master's program, and the chest pain came back. I'd already been to one doctor. They said, oh, it's costochondritis, inflammation around the rib cage, gave me painkillers, sent me home. Next doctor said, oh, you have bronchitis. Take this antibiotic, go home. And I'm like, I'm an educator. I'm around sick kids. All of this stuff sounds logical.
Yeah.
And the chest pain came back. And I called my cousin who I live with. I said, when I get home, you have to take me to the ER. This pain came back. And I'm on my way to the grad school class because I have to take this test. And I'm like, I'm going there and take a test. I'm in extreme pain.
Yeah.
Going to take the test and get up and go back home. And the pain subsided on the way back home. And I almost didn't go to the ER. But I said, go ahead, take me to the ER. They can give me a painkiller. And that's the first time they gave me an X-ray. They came back. They said, we found a mass in your lung. You're staying. And I'm like, I'm not staying. I have to go to work.
Yeah.
And my cousin's beside me. She says, they found a mass in your lung. You have to go. And the doctor said, do you want to see it? I said, sure. And the way I describe it, imagine you're looking at the night sky with binoculars. It's dark. Mm-hmm. The lobes of your lungs are supposed to be dark. And somebody takes a tissue, they ball it up and cover one of the lenses of that binocular. 3/4 of my lung were covered with a mass.
Wow.
And I said, guess I'm staying. And that would begin my journey. Similar to how you said, I'm sure your mom was treated with chemotherapy and radiation at first.
Yes.
Yep. Now, tell us a little bit about this second round, because I understand that you told me that you're on a clinical trial. How did you guys come about that decision?
Well, because I have 2 siblings, a brother and a sister, and we all went to the appointment with her, and he, sat down with us and gave us, all the options we could choose from. And because the thing now is quality of life, not necessarily getting rid of it, but making sure she's able to still function. So we just sat down and we went home and talked about it as a family, and we decided. And that was pretty much it.
So quality of life, that is a buzzword we hear a lot, in the community and advocacy, quality of life, progression-free survival, managing the toxicity. So did you have any fears when you heard the word clinical trial?
Yes, because, this is something new. It's a trial, and she's, one of the first ones to try it out. So, yeah, that's scary to know that anything could go wrong.
And how did you guys think about the clinical trial first?
No, the doctor came to us with it, and soon as we got the results that it was something on the scans.
Oh, okay, good. And how has that experience been, the treatment now compared to that first round?
The treatment now is a lot different, a lot easier. The first time was very aggressive. She was sick, a bunch of hospital stays. But this one, it's been fairly easy. Not easy, but compared to the first, yeah, it's better. Like she might have like a cold symptoms, like maybe 3 days after, and some, she has had bronchitis a few times from it. But it's a lot simpler than the last.
Oh, good. And anybody else, in the audience considering a clinical trial, we might be concerned about travel. How am I going to get to point A to B? Or what have you had any challenges?
Well, not really, since it's three of us and we just take turns. But they have offered, like the doctor offered transportation. He has given her, information. And it's a nurse that comes like a caseworker. If she needs anything, they can, But so far, we've been able to handle it.
And good. And that sounds like hope. So when she was diagnosed in 2018, they probably didn't even have these options for those clinical trials at that time. I've had a unique opportunity to sit at the table since 2006 and see these advancements. So I think, that's the message that we're sending out here, hope for small cell lung cancer patients.
Yeah.
And now, as a caregiver, and anybody out in the audience who's a caregiver, looking back at your experience, what's one message you would tell the caregiver that's with their loved one?
Just be patient. Try to be, positive, and just listen to them, and try not to put the the weight of the world on you. Ask for help if you need help. Even though you're not the one that's sick, everybody needs help.
And so to think about the whole patient as well, right?
Yeah, and along with the patient. Yeah.
And I used to tell new patients, make sure you bring somebody who has some paper. And do you take notes for your mother?
Yes, I used to take bags. I have a bag and I have puzzles, and I try to food. That's usually how we go to the appointments.
Oh, you stay with your mother for the appointments?
Mm-hmm. I stay, yeah, or my sister, whoever takes her that day, we stay the whole.
Good. Anything else you'd like to tell us?
Good. I know nothing comes to mind right off, top. Just, be there, stay positive, and like she said, there's hope. It's not necessarily a death sentence. It's have to have hope.
Mm-hmm. And yes, and I know, and thank you for our Amgen partners and everybody here today. So I'm very glad to hear your story. Thanks for sharing with us, and that the journey that you all had.
Yeah, and thank you guys for having me.
Good. Oh,
We have one other lung cancer surviving patient who was able to make it with us. Ms. Tony, do you mind if you could we'll have you stand up here. Is that all right? And if you could just share a few comments for us about your personal journey.
I started about a year or so ago. I went to the hospital because my feet and my ankles had swelled up so bad I couldn't hardly walk. Then, when I got over there to the Baptist Hospital in West Memphis, Arkansas, they kept taking treatments and stuff and carrying on. And then the doctor wanted to do some more, but he wouldn't explain what he was going to do for me. So after then, he came in there, and after I didn't want him to do any more treatments, he told me, he said, "You're going to die." And when he said, "You're going to die," that took something away from me. And I told him, "I tell you what you do. Give me my discharge papers and I'm finna get the hell up out of here." I said, "'Cause you're not the one that's gonna tell me when my turn is to die." So he told his nurse to stand there at the thing and listen to what I said and listen to what he said. And after he gave me my discharge papers, I left. I drove myself back home. After then, I didn't see him no more. But here now, I'm a year or so later. And when I got to that year, my Dr. Biden, I had told him about what had happened too. He said, you should go over there and tell him here I am. And I told him, I said, you know what, Dr. Biden, I thought about that. But then I thought about I don't owe him that pleasure. I owe the Lord the pleasure. And as long as he's keeping me, I'm going to stay going. I don't doubt anything. None at all. Because the faith is what you got to have. And if you don't have the faith, you don't have anything. And the Lord is your faith. The Lord is your opportunity. He's been mine, and I have loved it. And I'm going to continue on.
That's great. You know, even when I was diagnosed, I was telling them my story, and I wrote a memoir called "He Whispered Life." So you're right. You know, a message of faith, and here somebody could do the math. 2006, 2024, I'm still here, so I could tell the doctors that as well. You know, for new patients out there that are newly diagnosed, what's one message that you would tell them?
You have to keep a positive attitude with this. You can't be negative, because when you be negative, you draw yourself down. You draw your insides down. And that's one thing I'm not going to allow to happen to me. When the Lord says it's my time to go, I'm going to be ready to go. He's going to have me ready. But until then, I'm here.
Thank you so much. That's a great message for everyone.
Well, Ms. Tony, thank you very, very much for your words. That was really nice. Ms. Brown, come on. Thank you very much. And first off, for just being a caregiver, I know going through that experience myself, I know how difficult it is, but thank you very much. Let's give a hand for Ms. Lee also. Thank you. Thank you all very much. You know, for what we heard from Ms. Tony's experience, you know, few things can be as nerve-wracking as being told that you have a suspicious nodule, or in the case of Ms. Lee, that you have a suspicious lump. I'm sure that Isaac Hayes had our next speaker, Eric Flano, in mind when he wrote, "Who's the cat that won't cop out when there's danger all about?" Because we know there's one guy who's going to get the answer for it. This is going to be Dr. Flano. Dr. Flano is an associate professor in the Department of Medicine at Morehouse School of Medicine. He's chief and director of pulmonary and critical care and interventional pulmonary medicine. He's director of the lung cancer screening program and nodule clinic at Grady Hospital, Morehouse School of Medicine. Dr. Flano will discuss disparities, prevalence, screening, diagnosis of non-small cell lung cancer versus small cell lung cancer, risk factors, and stage. Dr. Flano.
And I'm supposed to do this in all of 20 minutes. So, first of all, Pastor, I want to thank you for, and Pearly Gates, thank you for inviting me here. And something unique about today that I haven't seen at some of the other places we've been is there's some youth in this audience today. And I think that's really important as we start talking about the direction that we want to go and the information we're going to give, because we can treat, but prevention's always the best treatment. Yeah. So I'm going to talk about lung cancer. Now, they know I tend to run long, so if they start like getting the big hook and yanking me off, don't be surprised. But there's going to be a lot of information here. I think it's important. I get really excited about this because this is what I want to do, and I think it's important to pass a lot of this on to you. But the first thing I want to talk about, and if you can't see it too clearly, you can move forward. If not, don't worry about it. We're going to go through it. Is explain exactly what lung cancer is. So, if you look all the way on the left, you'll see a normal cell, okay? That can be a prostate cell, it can be a breast cell, it can be, colon. But for this case, it's lung cancer. And what happens with any type of cancer is for some reason, the genetics the DNA of that normal cell changes. And then that cell starts to divide out of control. And so that's what you see. So you have the normal cell, you get a change, and it goes from divides, it goes one cell, then you have two of them when it divides, and you have four of them, you have eight of them, and then you get cancer. And that cancer starts to take over that organ of the body, and it can spread to other parts of the body and start taking over. So that's the basic of it, of any type of cancer. When we start talking about lung cancer, there's two main types, right? We're not really good at naming things in the medical profession. But when we think about the two main types, there are some that the cells are really small, right? Right. And they grow very fast. And that is what we call small cell lung cancer. Okay. And this is one of the more aggressive ones, right? It's the one that's linked highest to smoking. So when I start talking about smoking, you're going to get an understanding of why that's important. And then the other type, the cells are not so small. They're larger. It grows slower, right? But there's other causes linked to it, but it's still a big factor in terms of the lung cancer picture. And we call that one non-small cell lung cancer. Okay, so not very good, but that's the different types. And I'll get into that a little bit more. Okay, so when we talk about our lung cancer causes, we know, number one, about 95% of the time it's going to be smoking related. Okay, and I'm going to talk to you how it really impacts African Americans, right? Because we've learned that some of the bad effects of tobacco smoke are more pronounced in African Americans than other populations. Okay. Number two is radon. Has anybody here heard of radon before? Got it? So let me tell you what radon is. Radon is a breakdown product that comes out of the soil from uranium. Okay. It doesn't have a smell. It doesn't have a color. It doesn't have a taste. Okay. But it's radioactive. That's the number 2 cause in the United States of lung cancer. And it's so prevalent. I know in Georgia, I'm not really sure here about in Tennessee, but I know in Georgia specifically, if you're going to buy or sell a house, you have to have your house tested for radon. Okay. And here in Tennessee, 26.8% of the tests for radon are positive. They're above what's recommended by the EPA. That's 1 out of every 4 is positive. And I wonder which neighborhoods those houses are in. Okay, there's other causes too. There's asbestos, there's pollution. We're in Shelby County, right? Okay, so Shelby County is interesting because if we compare the ozone levels here in Shelby County, you are 7 times higher than the next one in line. It is the highest here. Okay, your rate of lung cancer is 2 times higher than the next one throughout the entire state. So something to keep in mind, especially where you're living, this population is going to be at risk. And then there's another component that is in just having lungs, because not all lung cancer is related to smoking or radon. Just having lungs puts you at a risk of developing lung cancer. Okay, so why is it specifically for blacks? Well, let's bring it home a little bit for Tennessee as well. If we look here and we look at the new cases of lung cancer and what's more acceptable and not acceptable, Tennessee, there's only 4 other states worse than you are in terms of lung cancer. And so this is something that really hits home that we really need to take, because you don't hear about it as a lot. And we start talking about disparities, these differences between races and the outcomes of lung cancer. I like to categorize it in 2 different ways. One, health, right? And the other part is health care. And when I start talking about health, we're going to think about the environmental factors that we're exposed to or that we expose ourselves to that impact our health. The tobacco, the pollution, okay, the lack of exercise, the dietary things. Those things factor in, but there's also biology, because I did mention to you, and I'm going to show you in a second how impactful this is, that the bad effects of smoking are more costly in our population. And so that's the biology. And those 2 things impact your health. The other thing is health care. Okay. And what's available? Is there opportunities for screening? Is there opportunities for getting the treatment that's needed? Are there clinical studies in the area that you're looking to try to get the treatment in? Okay. So, but specifically for African Americans, we have the highest death rates from lung cancer despite equal smoking rates of other races. We're less likely to get screened. We're more likely to get diagnosed later because we're not getting screened, and we're less likely to receive any treatment at all when you're diagnosed. Okay, so all those other factors of health versus healthcare factor in. Now, this is going to be really small, especially from the distance, but at the top level, we're looking at the predicted new cases of different types of cancer in this coming year. And on the bottom, we're going to see what's killing people, right? So on the top level, if we look for men, on the left-hand side, we expect to see prostate more than we see lung cancer, about 3 times as much new cases of prostate cancer versus lung cancer. Okay. So, but we start to see when we look at what's killing men, which of the cancers kill men, lung cancer jumps to number 1. Okay. For women, pretty easy, right? Breast cancer, about, again, it has a pointer. I just don't think it shows up on the screen. Yeah, but thank you. Thank you. Yeah, I'm just gonna point. Got you. Got you. Right, so same thing, about 3 times as much breast cancer will be diagnosed this year. But when you look at it, well, breast cancer still stays number 1, but only by less than 100 or so. Right. So it's not that equal. So 3 times as much, but still something is worse for African Americans diagnosed with cancer, especially lung cancer there. So here's what I'm talking about. On the left-hand side, we're going to look at the incidence of lung cancer, how often it's coming, and this is per new cases per 100,000 people. Okay. And what you see is African Americans lead. You're going to expect to see about 74, 75 new cases a year per 100,000 people. The next is whites, 64. Okay, so significant difference there. And then look at Native Americans and Alaskan Americans. Okay, because now you're down to 44. Right. But now let's compare that to the smoking rates. Top, African Americans. In the middle, whites. Lower, Native Americans. The yellow is men. The orange is women. And if you look at that, compare African Americans to whites, it's about the same, 23 versus 25. So you're smoking the same, but then go back over and you look, you have about a 10% difference in the likelihood of developing lung cancer. So that tells you something, right? That tells you something that we're more susceptible. And if you really want an example of that, look what's happening with the Native Americans, especially the men. They're smoking almost twice as much and have half the risk of lung cancer. Now, I don't encourage them to do that, but that's a reality that tells you there's something a little bit more that we need to be aware of so that we can factor in and how to make changes. Okay. When we look at smoking rates here in Tennessee, y'all can smoke. I mean, you guys are better than Louisiana and Alabama, but you're really up there. There's only about 2 worse than you. One of them's West Virginia, because we're all in this tobacco belt. But there's other things that factor in. Remember, I talked to you about your ozone levels and your air pollution here. There's about, estimated this year, about 557 new cases of lung cancer in this county alone. Right? So that's significant. So it tells you that there's some risk factors here that we need to pay attention to. Okay. So one thing I've learned over practicing for years is I don't just have to ask a patient how much they smoke. What do I have to ask them? What do you smoke? Right? Because there's been a lot that's been accepted or misconceived or the combination of both that's factoring into this. Okay. So something about smoking, and it is not the nicotine that, it's not the nicotine that causes the cancer. The nicotine is the addictive part of smoking. That keeps you coming back. It's the 6,000 other chemicals that are released from the arsenic, the formaldehyde, just any burning substances coming out there that you're inhaling and causing a genetic change and make those cells mutate and cause lung cancer. That's what's being released from that. But I will tell you, if nicotine were released today, the FDA would have a problem with it because it is one of the most addictive substances that we know. It is only overdone by cocaine and heroin. That's how addictive it is. But it's been accepted in our communities for so long that it's really kind of gets the pass, whatever else. But get back to the point. You take one cigarette, because we can measure and tell by what, comparing to one cigarette, the amount of nicotine is, what they're equal to other products that people are smoking. For example, one cigarette has about 8 milligrams of nicotine. Okay. One black and mild cigar, because I've had patients say, "Oh, I'm cutting down, doc." Right? I'm cutting down. I'm only smoking 2 or 3 a day. 2 or 3 what? Black and milds. Yeah? That has 100 milligrams. Right? You're about 12 cigarettes there in just one of those. So when you're saying you're cutting down to, 2 or 3 of those a day, you're about a pack and a half smoker. The larger cigars, 200 milligrams. That's 25 cigarettes. Okay. But the tobacco companies know this. They promote it in that fashion. Don't get me started on the mentholated cigarettes, right? Because they target their advertising for specific populations, especially when they got in trouble. And here, specifically in Tennessee, Juul has to pay you guys out $13 million because they were targeting youngsters with the flavored flavored vape pens, right? So there's a reason that they target them, but they're targeting our population because I don't think it's coincidence that they're called black and milds. Okay. Yeah. You guys, I've seen a lot of hookah bars, especially down here. And then I pass I don't want to call them out, the cash and carry up the road. And the big thing they say, cigarettes, tobacco and alcohol, right? And these are things in our population. But this is the new thing coming up, the hookah bars. You get this little container and a group of friends going and they pay for an hour session. They bring out and they have this little thing that they're passing around from everybody's dirty mouth to the next dirty mouth, and they're smoking the whole area and stuff like that. And this is the cool thing to say. So in 1 hour, each person's going to get about 100 puffs. Okay, in 1 hour, or about 200 puffs, and those 200 puffs are going to equate to about 100 cigarettes. So in that one session, these young people that think that this is the fashionable thing to do are getting about 5 cigarettes. That's a good nicotine load. And you keep doing this, especially with younger people and developing minds, and that's where the addiction comes. Marijuana use. And there's a big push. Legalize marijuana, legalize marijuana. And for the longest time, we did not know the relationship between marijuana and the development of lung cancer. But now that there's some studies that have really shown that there is a link, there is a relationship, and it's a little bit worse because there are people rolling it themselves. You don't know how fast they're rolling it, right? There's not filtered, and it's just straight in, okay? So this study showed that if you are a heavy marijuana user in your lifetime, that you have a twofold likelihood of developing lung cancer. Okay. So you might want to know what heavy is? 50 times, let's go, 50 times in your lifetime. Not in a week, like some of my patients, not in a month, in a lifetime. One shot, you have twofold risk of developing lung cancer. So the only way we can get ahead of this is to get screened, right? That's because we can, for those people that have these risk factors that we need to pay attention, the only way we're going to get ahead of this is to get screened. Got it. Okay. And this is what we know. Okay. A lot of times, a lot of us don't like to go to the doctors, right? I'm being a doctor. I don't know. Sometimes I don't like to go to them, but it happens. Okay. The reason that it's really important with getting screened, because the goal of screening is to find a disease before it started causing problems. So lung cancer is a little bit challenging, right? Because it develops in the part of the lung that you really don't have a lot of nerve tissue. So when somebody starts having a cough, or they're short of breath, or they're losing weight, or they're coughing up blood, or they just can't breathe like the same anymore, or they might have a pneumonia, they get treated, and it didn't really go away, and they get treated again, didn't go away, or something like that. Those are late signs of lung cancer. So waiting to that point is too long, because we know by the time somebody has symptoms, about 3/4 of those people have disease that's too far distant to be able to treat and cure. So screening is important. And the goal with screening is that you want to find that little spot out there in the lung tissue before it actually starts causing problem. And we know that that is the best way to do this is through getting a CAT scan once a year. That's all it takes if you meet the criteria to get screened. It's better than an x-ray, okay? And it's been shown to actually save or have you less likelihood of somebody who's high risk for developing lung cancer of dying from it by 25%. So who should get screened? The new criteria is if you're between the ages of 50 and 80, you're a candidate. If you have smoked at least a 20-pack year tobacco, 20-pack years of cigarette smoking. And so the way we get a 20-pack year is if you smoked 1 pack a day for 20 years, then that's a 20-pack year. If you smoke 2 packs a day for 10 years, that's 20. Okay. So this is what's important. Half a pack, 40 years, 20. So if you are above that, that's it. And if you smoked any time within the last 15 years, this is going to change, right? They're going to be a little bit more lenient because we're finding out that some populations are getting missed. And African Americans were getting missed on the original ones. And that's why it was specifically changed. So where is it and how much screening is occurring in those patients that we know are high risk here in Tennessee, where you're less than a national average? And I think part of it is getting the word out to know who's at risk factors and knowing and getting those people that you know, or that maybe yourself, to not blame yourself, not shame yourself or blame or shame that person, but say, let's get screened because it's important. It saves lives. Okay. So does finding it early actually improve the survival? Absolutely it does, because the best way that we can get somebody cured is to find it early to where it hasn't spread. And if we look at the way that they divide up in stage cancers, one of them is far on the left. If it's localized, you just have it in one spot, right? It hasn't spread to lymph nodes, hasn't gone anywhere, then it's just that way, the best chance of surviving, okay? If we make the comparison where whites are the blue and the red are blacks, you can see the whites are more likely to have it diagnosed early at an earlier stage than blacks are. If it's a regional one, the one in the middle here, then that's where it's just may have spread to a few lymph nodes, but it's still inside the lung system. Okay, it's about equal. But look who's more likely to have it diagnosed when it's a late stage, right? It's blacks, which means we really need to focus on the screening and prevention. And if we look at what's happening specifically here in Tennessee, you'll see the early diagnosis. The dark blue are whites, light blue are blacks, less likely to have it diagnosed early. Blacks are less likely to have it diagnosed early. The best way to get the treatment for cure is to have it cut out when it's found early, but blacks are less likely here in this state to have that. And the more likely here, the bottom one, is not to have any treatment at all. And sadly, that's where blacks here in Tennessee are suffering, of not having the opportunity or getting any treatment at all. Let's go. So to understand this, and I gotta keep moving because I tell you I get into this, so I gotta keep moving. So to understand this and why it's important on finding it early, right, is because remember I talked to you about that one cell that changes and it becomes 2 cells and it becomes 4 cells. That's what we call a doubling time, okay? And so there's amount of time it takes for those cells to double and take over. Let me put it to you this way. If I have a teaspoon of cancer cells sitting in your body, just a teaspoon size, there's a certain amount of time it takes for it to go from 1 teaspoon worth of cancer to 2 teaspoons to 4 teaspoons worth of cancer. And that's what we track. And the reason that's important, because I'm going to give you in time, when we look at about the non-small cell, remember the bigger one that goes a little bit slower? That time before you double up from that 1 teaspoon to 2 teaspoons and more and more and more till you got a cup and then it's spread everywhere, right? That's about 2 to 3 months, okay? So when you get diagnosed, you got to get that treatment, got to get things moving early, okay? But the best way, again, best treatment for non-small cell is going to be surgery. If not, options for chemotherapy or radiation come into play. The opportunity for surgery in Tennessee is not very good here. You can see you're closer to the bottom where you should be closer to the top. You're beneath the average here. But here's what's really impacting, especially here. If we take a comparison of, because remember we talked about surgical treatment, African Americans versus the other versus whites, in terms of likelihood of getting the curative treatment for lung cancer, which is surgery. You can look at white men in the blue, the red is black men, white women, black women. You're almost 30, African American men are 30% less likely to get the surgery that would be curative even when they qualify for it. So we need to focus in on that aspect of treatments and treatment availability. Okay. When we talk about small cell, remember I said that this is the most aggressive, right? So when you have that 1 teaspoon of those little cells, right, which are already a bunch, the time you go from 2 teaspoons is 30 days, 1 month. So you get diagnosed and they delay treatment for 30 days, it's twice as much. In another 30 days, it's 4 times as much. So the time clock starts ticking. Right. This is the most aggressive. It's so aggressive that surgery really isn't an option for it. We stage it by whether it's in one spot or if it's throughout the rest of the body. And even with that, even with it, it's the most aggressive because in about 5 years, how we measure it, 5 years, only 5 to 10% of people are with it, diagnosed with it, are still alive. Hats off to those who are still here. I think they deserve a hand because they're one of the real. And if you have the extensive stage at the time of your diagnosis, even if you get treatment, right, your still lifespan is about 6 months to a year. And with treatment, only about 10% are still disease-free after 2 years of getting the treatment. Recurrence is very likely with them. Again, chemotherapy and radiation is probably the treatment of choice. There is new hope, right? There is new hope with clinical trials that have been looking at taking your immune system and boosting it and helping fight off the cancer. And it makes it important to think about being involved in some of the clinical trials. There's some bad history about clinical trials and African Americans being involved in that. That's kind of past, right? That's kind of in the past. We've recognized it. There have been changes. The studies are safer right now. But we've got to think there are benefits to being involved in clinical trials. One is you're either going to get the standard treatment or you're going to get a new treatment. There's none of this, you're going to get left behind and just get experimented on. The other thing is there becomes an understanding about how disease plays a role in our population, which is important because a lot of the treatments being recommended are being recommended for other groups because we haven't participated in these trials. And for those patients that are underinsured, don't have a lot of money, you have an opportunity for treatment that could benefit you and that could extend your life. The thing about it is, if we look all the way to the right side and we look at African Americans participating in clinical trials versus whites, whites are about 83% of the trials. Blacks are only 6%. So you got to think that the decisions, the information that we get from these trials are representing not our population. So a few take-home points to keep in mind. One is prevention, right? So this is a study that looked at middle school students, okay? And I won't go through all the numbers, but I will say that any of them using some sort of tobacco product is somewhere between 4 to 5% of middle school. It only gets worse when they get to high school. And it started out with these vape pens, which were easy, but you know what happens is those cost money, and then the kids realize they don't have much money, and then all of a sudden they end up going to cigarettes, right? But the other component is what we show and teach our kids, because we can't tell our kids not to smoke and they see us doing it. We can't tell them marijuana is bad for you, right? And then they see us doing it. Okay. Again, remember this. If you're between the ages of 50 to 80, you have at least a 20-pack year tobacco use history, or you know somebody that does, and you have smoked sometime in the last 15 years, you need to take that information, get that person to get screened. Not blaming, don't feel guilty about it. Let's try to save your life. Okay. And remember, clinical trials do offer some opportunities for us. You'll hear about that a little bit later, but keep those in mind because I think we're selling ourselves short with respect to getting treatment that will help us in our community. Right. And I could go on, but Wayne's going to get upset, but thank you very much.
Thank you very much, Dr. Flannel. I want to remind you that at the conclusion of our speakers, we're going to have a time for question and answers. So please, if you're thinking about something, you try to write it down or at least try to remember it, because we will have an opportunity for question and answers after that. If I could, mention, Ms. Tony said something I thought that was very interesting. She said that she wasn't going to go back and shame her first physician. And I thought that was very insightful. I'm assuming that you weren't going to waste your time going back to somebody that didn't do her right. But on the other hand, it's important, though, we're not going to chastise and shame our friends and family members who are current smokers. Rather, as Dr. Flannel said, we're going to encourage them to stop. And for those who haven't started, we're going to try to encourage people to not start. So again, there will be time for question and answer. Let's move on to the next part of this, because once the diagnosis of small cell lung cancer has been made, for too many of us, uncertainty of this new disease leads to fear and distress, and sometimes paralysis when we don't act upon it. To put those fears and concerns to rest, we have as our next speaker, Dr. Osa Obeidi. And I got to, again, go back to the canon from Stacks. Like Sam and Dave say, hold on, I'm coming. Dr. Obeidi. Dr. Obeidi is a graduate of the University of Benin Faculty of Medicine in Benin City, Nigeria. He completed his residency in internal medicine at Woodhull Medical Center in Brooklyn, New York, and a fellowship in hematology and oncology at the University of Tennessee Health Science Center here in Memphis. He is currently affiliated with the Baptist Cancer Center, and he will be talking to us about treatment advances in small cell lung cancer and clinical trials. Dr. Obeidi.
Good morning, everyone. Thank you for the opportunity, Reverend, and the HEAL Collaborative. This is a topic that's near and dear to my heart, taking care of patients who have lung cancer. So my mandate is to talk about the hope in research. We often hear research and, what's the whole idea about putting patients on clinical trials. And I'm happy Dr. Flannel has sort of laid the groundwork. He's making my job much easier in the sense that, this is how we're going to make advances. This is how we're going to improve the care of our patients. And I'm glad that there are some young ones in the audience today. So the HEAL Collaborative, when they reached out to me, I thought about the best way to bring this topic to the audience, and I thought about defining some of these terms. Research, so that's part of what I'm going to do right now, if I can advance my slide. Okay, so hope. What's hope? Hope is to trust in, wait for, or look, or desire for something that you are anxious or eager to happen in your life or in the life of a loved one. It can take various forms. I put the picture of the dog there. Maybe he's hoping for his owner to come join him. You can see the look on his face. So it's a noun, it's a verb. It can represent aspiration, desire, a wish, expectation, different things to different people. Now, in terms of research, what's the definition? It's one definition is a systemic investigation into and study of materials and sources to establish facts and reach new conclusions. So by that, we mean there's a status quo and you're trying to see whether you can improve on that. Now, in clinical trials and in oncology and medicine generally, that involves exposing patients to a new way of doing things and seeing if that causes an improvement in your patient's outcome, their survival. So as Dr. Feno mentioned, I mean, the figures are quite small, but I put a pictogram of small cell cancer microscopic view there just to let us see what this looks like under the microscope. Now, as Dr. Feno mentioned, small cell just describes the way the cells look under the microscope compared to non-small cell. The cells are a little bit bigger. They are, not as rapidly progressive as you have with small cell. Small cell is a bad actor. It grows fast. It by the time it's discovered, many times it's already extensive stage, which we call, there's limited stage and extensive stage. So these are some of the symptoms that patients could have with small cell lung cancer, as Dr. Feno mentioned: coughing up blood, weight loss, chest pain. Those are signs of an advanced disease. So again, screening is the best way to pick this up early. This is just a pictogram looking at, a patient's lung. So you see, this is the airway, the bronchial tree, and this is what cancer looks like in the body. That's the cut surface, and you see that yellow area representing the small cell. So the next slide talks about limited and extensive stage. When you talk about limited stage, as I mentioned earlier, it's equivalent to what we call TNM. TNM stands for tumor, node, and metastasis. So anything between stage 1 to 3 is limited stage. We refer to a radiation port. So if someone has a cancer in a part of the lung that the radiation doctor can put inside one field and treat, we call that limited stage, essentially. But if they have a spot in the lung and one in the brain and one in the liver, you can't radiate the whole body. So treatment options get more and more limited if the cancer has spread to other parts of the body. So what are the treatments available for lung cancer generally? As Dr. Feno mentioned, surgery is the best treatment. That's usually available if it's caught early, and a small nodule in the lung can be surgically removed. Radiation is also a treatment option, and then chemotherapy. What is chemotherapy? It's basically giving a drug to a patient in the hope of destroying rapidly dividing cells, of which cancer cells are an example. So not only do the chemotherapy cannot tell the difference between a cancer cell and, say, your hair follicles or your GI tract or your red cells. So patients get chemo and their blood counts will drop, the cancer cells will die, but they have side effects. So it is not very specific. Now, something new that has come to the field of cancer treatment is immunotherapy. Now, this is different. Immunotherapy basically wakes up your body's immune system and asks it to go after the cancer. So this first came to attention in melanoma. We noticed that patients with melanoma, sometimes spontaneously the melanoma disappears. And the research went into that and said, what exactly is happening here? And what became evident was that the immune system is fighting the cancer. So people have exploited that to rev up the immune system to go after cancer. So that's essentially what immunotherapy is, and it's really revolutionized the treatment of small cell lung cancer. The last thing on the slide there is something called bispecific T-cell engager. Now that's a new treatment, and Dr. Feno mentioned that it's tarlatamab, and that's a drug that has. We just finished our annual meeting in Chicago last week, and it was quite an exciting meeting because we are now beginning to actually have things to offer our patients. In small cell, for 40 years, it was just chemo and, in the last 10 years, immunotherapy. But now we have things like this bispecific T-cell engager, which is going to be quite significant for our patients. So 5-year survival rates for small cell lung cancer. So this is looking at the period from 1975 to 2016. You see all stages about 6.5%. regionalized, like Dr. Feno mentioned, and distant, the survival is dismal. It's not good. And then this is a slide looking at 1975 to 2016. You again see where you compare small cell and non-small cell, the survival is usually better with non-small cell. There are many treatment options, many alternative agents that can be given for non-small cell. And as Dr. Feno mentioned again, the doubling time is longer. Patients, the cancer doesn't grow as fast as small cell. Small cell is rapidly growing, rapidly dividing. This is another slide looking at, it doesn't project very well, the small cell and non-small cell population, again, telling us the difference in survival. So there's a recent trial called the Adriatic Clinical Trial. That was another major advancement in our care of lung cancer patients. So there's a medication called durvalumab, which is an immunotherapy drug. And what we found initially, the way we manage small cell is we give, especially if it's still localized, it hasn't spread, you give chemo and radiation and basically hope for the best. But now with this clinical trial, there's a drug called durvalumab, which is an immunotherapy drug, which has completely, what happens after a clinical trial, this came from a clinical trial, patients who finished that course of chemo radiation, they went on this drug called durvalumab, and the results show that at 18 months, you have 48% of patients who received this Imfinzi or durvalumab were still free of progression, compared to 36% of patients who received placebo. This is an important advancement in small cell, and this is something I can offer my patients in clinic tomorrow or Monday if I find that they are progressing. So this is really important. Again, at 24 months, the progression-free survival for patients who received durvalumab in this clinical trial called Adriatic was 46% compared to 34% of patients who received placebo. Major advancement and giving us hope. So I try to talk about some of the reasons for this advanced survival in small cell lung cancer. It cuts across not just treatment, but diagnosis. We have better ways of diagnosing patients now. CT scans, PET scans, bronchoscopy, which Dr. Feno is an expert on. You go into the lung, you find the cancer, get a small piece of it, and that's how we get a diagnosis. You can do all the CT scans you want, you can do all the MRIs, until you get tissue for the pathologist to look at under the microscope and give you the diagnosis. Well, you don't really have a diagnosis yet. Another modality of treatment or other modalities that are available now include something called SBRT. It's a different way of delivering radiation, focused high dose for a shorter period of time. So it's quite an advancement. And as I mentioned earlier, things like immunotherapy and these bispecific T-cell engagers and antibody drug conjugates, all these are coming down the pike because of clinical trials. Okay? And then supportive care during and after treatment. So how do we leverage all these modalities now and in the future? Well, clinical trials. We have to participate in clinical trials. There's no getting around that. Again, I keep referring to what Dr. Feno said. When you have the results of a trial telling you that only 3% of the population was African American or Black, then we're just trying to extrapolate and say, hopefully it works in African American patients. I can't stress enough the need to participate in trials. We have to, whenever trials are discussed or we are approached for trials, we need to really consider joining a clinical trial, because it's going to help not just for today, but for the future. Many of the treatments that we call standard of care today were once clinical trials. That's the truth about it. So this is my last slide. I came across this quote maybe 15 years ago. Jean-Marie Charcot is a French neurologist who lived in the early, mid-19th century. And he said, we need to keep looking in spite of everything. Let us keep searching for indeed it is the best way of finding. And perhaps, thanks to our effort, the verdict we will give such a patient tomorrow will not have to be the same that we might give him today. This has been a major tenet for me, because I want to be able to give my patients hope and give them better options in the future. So with that, thank you for your attention.
Thank you very much, Dr. Obeidi. We appreciate that. Stan Watson, who is with the Hill Collaborative, is from Memphis. By any chance, did anybody here know Stan? Any people who actually met? Okay. Now, I mean, I'm sure there are others, but you're the only one honest enough to admit it, that you know Stan Watson. So I applaud you, sir. And, and I mention that because if you think about what we just heard from Dr. Obeidi, the landscape of lung cancer treatment, particularly non-small cell lung cancer treatment, is changing and can be very confusing. And if you don't have somebody with you through this journey, sometimes you can get down. And of course, as B.B. King said, when you're getting down and depressed, the thrill is gone. And sometimes it's hard to keep on moving on. So what we need is someone who will be by our side and guide us along this way. And I can't say it any better than the Staple Singers. What we want is somebody who will say to us, I'll take you there. Our next speaker, Ms. Ursula Mathis, is such a person. Ms. Mathis obtained her BS in biology from Florida Memorial University, followed by an MBA from the American Intercontinental University. She is currently the Director of Quality Comprehensive Programs and Services in the Oncology Service Line at the Phoebe Putney Health System in Albany, Georgia. Ms. Mathis will discuss navigation, care, and support for the small cell lung cancer patient. Sister Mathis.
Thank you, and I'm so glad that you asked. First, thank you all for having me. Thank you, Pastor, for welcoming us into your house of worship. It is absolutely beautiful. And thank you all for your attendance and your interest in getting this education. But navigation indeed is so important. And I always like to say, that it is our GPS to our healthcare journey. And we say it's our GPS is that it's our roadmap. It's what helps us navigate from point A to point B. Whether that is psychosocially, whether that's our appointments, whether that's someone that sits in your appointments with you to help you understand, whether it's your support system, whether it's your medical professional, whether it's the person that you bring with you. Navigation is a vital role and a vital part in the success of your healthcare journey. And why do we say that? Because first, we know that it is true, and Ms. Terry, you said it best, that there's a lot of mistrust in our healthcare systems. That comes from history. Some of it's myths, some of it's hearsay, a lot of it's facts, but the reality is it exists. But what we need to do when we're navigating this process, so some of the navigation starts with us and self-advocacy. But when we're navigating this process, we have to wean the good out and wean the bad out and do what is best for us personally. For your personal journey, for your personal experience, for your diagnosis, because your diagnosis is unlike anyone else's. There's something that's a little different or a little unique or a little something that makes it different from either your sisters, your moms, your friends, or anyone else's that you've heard about. So we have to be able to navigate this process for ourselves and to connect and network with people that can help us through this process. The medicine's different from day to day, furthermore, year to year. So when we talk about navigation, it's that person that meets you where you are, and that have to start with you. You have to be able to meet yourself where you are. And then you meet up with medical professionals or with friends or a lay person that is willing to walk that journey with you. At Baptist, my institution and most institutions, they have hired navigators that most of them are nurses and those nurses contact you prior to your appointments, meet you for your first appointment. They sit in a room with you so they can help translate for you what the doctor said, because most people, we know that when you hear that diagnosis that you have cancer, you lose about the rest of that. You only retain about 5% of the rest of everything else that they've said. And that's to be expected. Anytime anyone hits you with some news that is either tragic or overwhelming, your mind automatically goes to what next? What am I going to do? How's this going to affect my family? How's this going to affect my finances? Am I going to die? Patients always tell me that's the first thing that they said. So that navigator is there so that when you get over those emotions, or you have the opportunity to sit and speak with them outside the presence of your physician or your healthcare provider, they can regurgitate some of that information. They can say, okay, we got to get this test done. I'm going to help make this appointment for you, and I'm going to introduce you to our social workers so they can help you with some social services. Let's identify some of your barriers to care or treatment. Let's see what it's going to take for you to have optimal outcomes in this trial. And then we're going to talk about clinical trials a little bit when we talk about that. We have to first educate ourselves as to what's available and what's not available. The navigator is going to be a major role in that support. But also, the patient plays a major role in that as well. As we've said it, and I'm going to repeat what's been said because I have to ditto it. If we don't participate, then the outcomes are not in our favor. If we don't participate, we're taking medicine that we hope will work. In order for us to know whether it would work, we have to participate in the clinical trials for favorable outcomes. We get out of a situation what we put into the situation. So if we don't put anything in, we don't get anything out. Okay, so we want to participate in clinical trials, but your participation in clinical trials needs to be informed. You need to be a part of that decision. I'm a real big advocate in navigation for shared decision making. You need to be a part of every decision that occurs in your healthcare journey, whether you participate in the clinical trial or you don't, whether you take chemo or you choose not to, whether you do the radiation, but you need to be able to make informed decisions about whether you want to do it, whether you do not want to do it, your whys, your pros, and your cons. And a navigator can help you through that process, but the help really starts with you. You want to be informed. You want to be able to have these conversations with your family members. You want to know what your pros and cons are, what your risk factors are, what you will be able to do. What is life after cancer going to look like for you? What is life during your treatment and during cancer? How is this going to affect my finances? How is this going to affect my mental health? All of these things have to be discussed. It's not just about going to an appointment, finding out you have something, and saying, what do I do next? And then dealing with whatever outcomes and letting the chips fall where they may. We're past that. And we have to be past that because we have to take a vital role in our healthcare journey. We have to be able to advocate and navigate for ourselves. So that means we got to meet ourselves where we are. We got to acknowledge our social determinants of health. We have to acknowledge our social habits. We control our habits. We don't let our habits control us. We're not ashamed of what we do, but we know that we got to do better. We know that we've got to make decisions to say, okay, I'm going to do this less until I can get to the point where I can stop. There's no judgment in self. There can't be any judgment in wanting to do better and wanting optimal outcomes for you and your loved ones and your family. So if you don't judge you, then you don't let others judge you. But when you allow what others affect and say by you, that's because you self-consciously have some judgment for yourself. So you don't judge you, you acknowledge, this is what I do, it is what it is. Everybody do something, we all have our vices. We all do something. Trust me. Me, you, everybody, we all do something. And we enjoy doing it. How about that? But when it comes to our healthcare journey, we have to say, okay, I'm going to do this less, or I got to get on board with this, or I'm going to have to exercise. I got to change the way I eat. I got to change the environments because I want to live. And that's what it's got to be for. And I want to live and I want quality of life where I live it. Okay. So we have to be able to have conversations with our primary care physicians. Everyone needs one. If you don't have one, everyone needs a primary care physician. It's the quarterback to your healthcare journey. And what your primary care physician does is it manages all these social determinants and all these habits and all these comorbidities so that when we do face serious illnesses and disease, those are under control. That we have a history, we have a pattern of what our EKG looks like, so we know whether we can take a medication that's going to affect our heart health. We have a pattern of how we've monitored our blood pressure. We have a pattern of what our cholesterol normally is, what our glucose normally is. So that when we see a spike or an elevation, we can say that's their norm, or this is a reaction or a side effect to something that we're doing. But without that history, we start from ground zero. And that's why the numbers look like what Dr. Fanal said, because we're starting from ground zero. And at this day and this age, there's so much out here. The resources are so available. We know that the source comes from our Father, and that's why we're here. But He provides resources that we need to use. The resources are there so that we don't have to be the highest rate of people that don't get treatment. We don't have to have the highest mortality rates. There don't have to be these disparities. They're always going to exist, but we can lessen the curve because we have to start with us. But as long as we're dependent on someone else to do it for us, long as we feel that somehow or another they should think we need to be included, it's not going to happen. We have to be the they. We have to advocate that this is what we are deserve, this is what we're going to do, and this is how we're going to do it. And this is what I am going to do for me and my family as we move forward in our healthcare journeys. So our reality is that there are lower screening rates, lower treatment rates. But why? We know that we need our mammograms. We know that we need our colonoscopies.
Yeah.
So we have to know that we have a smoking history, 20-pack year, we have a certain age, we have these chronic coughs, we notice the differences in our oxygen level. We know that we need a lung cancer screening. So then what if you say, okay, but I didn't smoke, but I've been around smokers. I may have been exposed to some radon and some asbestos. That's why we need our primary care physicians, because you can still get tested and it not be called a screening. We can't take exceptions and guidelines and rules and stop at that. We want to follow them when we meet that criteria. But when we feel like something's off or something's wrong, and I have a family history, and at a certain age, all my family members have been diagnosed with this disease, think what you can do to be preventive and to be proactive, not reactive when it comes to you. And that's having conversations with that primary care physician. That's getting to know your doctor and letting your doctor get to know you. That's doing your self-exam so that you know what feels right and what doesn't feel right, what's new and what's been there forever and has never changed. That's meeting yourself where you are. That's acknowledging that I smoke, but I'm gonna do better. That's acknowledging that I smoke, but I'm gonna smoke less. That I'm not gonna smoke where I lay my head. That I'm not gonna smoke inside anymore. That I'm not gonna endanger others when I smoke. If this is what I choose, I'm not gonna make it other people's choice. It's inconveniencing yourself for bad habits. And then eventually the habit lessens because I've got to be inconvenienced to do it. When they stop smoking in restaurants,
Yeah.
people still go.
Right.
But now the discipline is that they can't smoke in them. Okay? So I'm a big casino goer. I love a casino. But every time you go in a casino, you come out smelling like smoke. Because that's what people do. They smoke and gamble. That's how they can keep doing it. You can do it all night. Smoke and gamble. It just keeps going. Your adrenaline gets going and you just do it. But if they were to limit smoking in casinos, they would limit the crowd. So certain things are created for certain environments. and they're not they're put in certain areas. And I went to go there with that fact because when we think about the statistics he showed about the middle school girls, we did a talk with Hill and we did some kids one year. And the middle schoolers, he didn't mention girls, but girls are the higher rates of the middle schools that are smoking. And then, like he said, when they cannot smoke vape, they start with cigarettes. But they're getting cigarettes from the corner stores because they sell single cigarettes.
Yeah.
So I've made a conscious decision that I don't patronize stores that sell single cigarettes because they don't have the best interests of kids that look like me. And they're changing the trajectory of those lives. Because if they start smoking in middle school, by the time they get to high school, it's not going to be cigarettes. Because the addiction starts there. Their minds are vulnerable. Their immune systems are vulnerable. Their addictions are vulnerable. Then as they have addictive genes that have been hereditary, that makes them even more vulnerable. But I would not patronize anyone that's making it easily accessible to destroy the future of my generation, or the future of the trajectory of children that we're looking to move the world forward, that we're looking to be the next scientists, that we're looking to be the next doctors, that we're looking to motivate. Think about where those areas that those stores are mostly. They're in our neighborhoods. When he said Black and Miles is not coincidence, it's catered to a certain population and generation of people. The stores that sell underage alcohol, underage nicotine, they're in our neighborhoods. And they're put there for a reason. But if we stop patronizing them, we see some boarded up all the time. All the time. Because we have to navigate the process for ourselves. We have to think outside the box. This thing can't be transactional. You can't want to sign up for a clinical trial because there's a trinket or because there's a gift card. It has to be transformational for you. It has to be because this is going to be optimal outcomes for me and it's going to make a difference for the next generation. We have to change our mindsets that we can't wait for someone to navigate this process for us. We've got to be proactive and want to navigate it for ourselves. It's mind-shifting mindset change, and it has to start with us. Let's think about transformations and not transactions. Thank you all for having me.
Thank you very much, Ms. Mathis. As I bring up our next speaker, some people see a problem and wait to get invited to get involved. And then there are folks like our next speaker, Ms. Lisa Giroru, who, to paraphrase Kim Weston from Stax Records, I might add, by way of Motown, but is more apt to say, when something is wrong with my baby, or in this case, her people, something is wrong with me, and she wants to become part of the solution. Ms. Giroru received her Bachelor of Business Administration and with a concentration in marketing from the Mecca, that's Howard University, for those of you uninitiated. She is on the Health Equity Council of the Longevity Foundation and is currently Director of Global Advocacy Relations, Thoracic and Gastrointestinal Cancers with Amgen. She will advise us as to what our next steps should be. Ms. Giroux.
Good morning, everyone. Thank you for being here today. Thank you to Pastor Gillespie and to Hill Collaborative for making this event happen. At Amgen, our mission is to serve patients, and in doing that, it means we also have to serve the communities where these patients live. So that's why we're here today, because information like this doesn't always get brought directly to you. And we want to be a part of the solution in making sure that you have access to the information you need to make informed treatment decisions. I'm not here to speak as a speaker. I'm really focused on what is the call to action. You got up early today because you cared, you wanted the knowledge. You're here today because you care. And so the call to action is simple. Don't let the information that you heard today sit with you. You have to take action on what you've heard today. And what that means is sharing it with others. It means thinking about your own health. And when you have your next doctor's appointment, talking to your doctor about what you've heard. I want to make sure that by being here today, you walk away with the understanding that you don't have to be a smoker to get lung cancer. You just have to have lungs in your body, and everybody in this room has lungs. So your behavior isn't always going to be the driver of whether you get lung cancer. The other thing I want to highlight is that sometimes we hear from patients who find out they have lung cancer by pure coincidence. They've gone in, they had an accident. One woman shared with us her experience was she was going to a concert, fell down the stairs on her way out, ultimately went to the doctor the next day and had to get a scan, and that's how they found out she had lung cancer. So when you go for your doctor's appointments, make sure you're telling them everything, because it's the little thing that may make the difference. And when you get those results, sometimes you get them in a portal, and there's a lot of information on there. Read them. And if you don't know what they say, call your doctor's office and ask them to talk you through them. There may be information on there that is critical. I can tell you from personal experience, I had to have a scan, a CT scan, and there was a little statement on there, incidental nodule found. If I didn't work in the field that I work in, that would have meant nothing to me. I would have saw it, ignored it, and kept going. But what it said to me is, oh, there's something there that shouldn't be there, and I need to make a phone call and ask somebody about it. And so for each of you, I just say, be not only informed, but be your own advocate, be an advocate of your family and your friends to take action for their health, because that's how we have the opportunity to live our best, healthiest, happiest lives. And if a clinical trial opportunity is presented to you, ask questions, learn about whether it offers you an opportunity for hope. And more importantly, if you're going through your journey and that opportunity isn't offered to you, ask for it, because it's not always going to be presented, but you have the power. Knowledge and action equals empowerment, and that's what we want for you. So thank you.
If I could, I'd like to bring our speakers, Dr. Flano, Dr. Obaby, and Ms. Mathis, back up here. I'm letting Dr. Flano touch those microphones since I might have messed them up, so he'll get blamed for it. Me.
It's not the one, the pointed one.
Since you've had so much extensive experience being on stage. Yeah. Look.
Second.
Now, again, if you have a question, please raise your hand, and your friend Stan's going to try to make it around to ask the frame. But let me begin. You guys here. There's something you didn't touch upon, which we sometimes hear. And you, to a little bit of degree there, you did touch on a little bit, Ms. Mathis. And that's it. When she was saying, if you're smoking, go outside and things like that. Which gets us to primary smoking, secondhand smoke, and tertiary smoke. What is the difference, and are they equally risky for us?
So yeah, the primary smoke is pretty obvious. The secondhand smoke that you're exposed to, that comes from what other people inhaled and exhaled and you're exposed to. So if you're in a house with a smoker, you're in an environment with a smoker, that is. Now we do know that those people that are exposed to secondhand smoke do have a higher risk of developing lung cancer. But it's hard to quantitate exactly how much. If you have a smoker, they say, oh, I smoke this many packs this often. But with the secondhand smoker, we're never really sure. But we do know that there is a link to that, and that's something to discuss with your primary care physician, that I've been exposed to a lot of secondhand smoke.
What about the third-hand smoke? That smoke that is on the carpet, especially when you think about little kids. They crawl around on the carpet. So it's on the carpet, on the couch, on the pillows and things. Is that also a risk factor for us?
Yeah, the specific risk factor for lung cancer is hard to to tell on that, but we do know, especially it's a good description of kids and younger ones that are in the same household and whatever else, more likely to develop respiratory diseases, allergic rhinitis, or, they get their allergies are off the lot. They get asthma as linked higher, especially in our population.
Dr. O'Baby, would you address, Dr. Snow touched upon it a little bit, but when we think about compounding effects besides cigarette, there are environmental stimuli.
Yeah.
Is that something that the primary care physician should be looking at when we're coming in for examination to give a better idea about our risk factors for developing lung cancer?
Yes, I think that's a more holistic approach to taking care of our patients. It's the totality of their experience, not only smoking history, where they live, what their job is actually, the occupation. That's important. Asbestos exposure, we know that's and as Dr. Flano said, radon. I mean, I myself often forget that that's number two, and it's pervasive. It's everywhere. So sometimes it's very easy to focus on just one aspect. Oh, smoking. How long have you smoked and all that? But I think it's important to look in the totality.
Yeah, and I can add on a little bit too. Like asbestos, if you're up late at night and you hear these commercials, have you exposed to asbestos, mesothelioma, and whatever else? Okay, so asbestos is, an insulation fiber. It gets in the lungs. It just causes a lot of problems. There's two types of cancers that develop from being exposed to asbestos. One is mesothelioma, which you hear about, right? And then that outlines the lung. It's a terrible disease. We know if you have mesothelioma, you were exposed to asbestos. But if you were exposed to asbestos, you're more likely to develop lung cancer. And the thing about that is I can put up those risk factors. If asbestos, you have about 10 times likelihood of developing lung cancer. If you smoke, you're about 10 times the risk, right? But they're multiplicative. So if you've had them both, you're about 60 times more likely. And if you're a spouse or a child of somebody that has worked with asbestos and it's on their clothes and they come home and whatever else, you're likely to develop it too, because that's the exposure you get tertiary and secondary.
How many of you have had a discussion with your primary provider about getting screened?
One.
Ms. Mathis, one person. Is somebody missing the boat here? Thank you, ma'am.
Absolutely. First of all, your providers are missing the boat because they should bring the conversation up. But now that you've been educated and you're informed, when you go back, you bring up the conversation.
I think we can't stress enough the importance of being screened. So let's go back to the screening concept. Why were the criteria established as what they are? And does that going to include some African Americans, or are we missing the boat on that?
So we've seen a couple of changes in the criteria. The criteria were established. They did a big study looking at, people who smoked different rates and had, exposures in different ages. And they found that group that was you'd hit the most for your money, right? So that age range and then the tobacco exposure range. The original criteria was 55 to 80. Now it's 50. The original criteria was 30-pack years. Now it's 20. So the reason why it changed is in the study they found that in the original criteria, they were missing African Americans. One of the studies, there were three studies actually found. But one of the studies is a study that I wrote with some of my colleagues, because I diagnosed about 180 new cases of lung cancer a year. 95% of those are African Americans. I had 29-year-olds, 34-year-olds with stage 4 lung cancer. Those people would have never had the opportunity to even get screened. But that's what I was diagnosing. I found that of of those patients that didn't meet the criteria, 11% of them were underneath the age to get screened, and 6% were above it where they said you should have stopped, and they were all African Americans. Okay. The reason that happened is because in the original trials, even though the population of the U.S. is about 15% African Americans, only 4% were in the study. So what happened is the criteria was based not on us, because we weren't part of the studies.
We'll come to a question, man. I just wonder, how many of you, when Dr. Flano was talking about marijuana, you have to raise your hands, when Dr. Flano was talking about marijuana use, started counting? Yeah, you can admit it. No? Thank you. So, I'm going to have the question. Go ahead, Stan, you have a question for us.
Thank you. Good afternoon, everybody. I wanted to ask the question, how often do we need to get lung cancer screenings? Because breast cancer screenings are every year, and then you have colonoscopies every 10 years. How often should we notify our PCP that, we want to get a lung cancer screen? And do insurance companies just pay for them if you just want them? Because, that's another thing. Will we have to pay out of pocket for this screening? Or is it preventive?
Ms. Mathis, why don't you start off with that?
Trust me. So it's once a year.
Okay.
Yeah, it's a CT scan. It is done once a year. By the time you walk in, get changed, get on the table, get your screen, and get off the table, should be about 20 minutes. Okay. And they're recommending you follow at least for 15 years after you stop smoking. But it's once a year. It takes about 20 minutes. It is covered. It's covered by the insurance companies as preventive screening, and Medicaid and Medicare cover it as well.
How readily available are these tests? Are they at every hospital? Dr. Baby?
Yes, at least I can speak to what happens at my institution. It's available. I think the challenge remains awareness. We do know that, unfortunately, even in some instances within primary care, we're missing opportunity to screen and detect. So that's why such events are really important, because it empowers our patients. And it's not that the doctor doesn't want to do it, maybe they're too busy. Or at Baptist, we have actually developed software that reminds the physicians. So it pops up, when they open the chat and says, and that's one of the areas that I'm really also very hopeful about is artificial intelligence. So, and computer-based algorithms that will pop up and say, Doc, this patient may be a candidate for lung cancer screening. You're supposed to act on that. So everything that can be done to help, screen, because as Dr. Flano said, the guideline has boundaries, right? So unfortunately, we're still going to miss some patients. So our hope is to capture those patients within the guidelines that are supposed to be screened and get them screened.
Did you have another part of your question?
Yes, I do. There are other, I've never been a smoker, and but my mother and father smoked for like 30 years, and neither one of them died from lung cancer. However, I do notice that some of the chemicals in my home that I use for cleaning, like Pine Sol, bleach, Clorox, and other things like that, are very pungent odors. And I was wondering, does those type of things cause like respiratory issues as well as possibly lung cancer?
Let's take that into two parts, because one thing that you always hear about people, Mama and Dad or Bob and Joe smoked like a chimney stack and they didn't get sick. Well, they didn't get lung cancer. So does everyone who smokes go necessarily get lung cancer? And then two, I think she also addresses, not only we think in terms of environmental factors that can cause cancer, is think outside of the house, but there are those in-home environmental factors that can give rise to lung disease also. Who wants to start off with that?
I can start. I mean, with regard to the question about, Mr. Smith or Mr. John smoked for 100 years, and so the way I answer that to my patients is that you don't have Mr. Smith's or Mr. John's genetics. You cannot extrapolate and say, since he didn't get lung cancer, I should be fine too. No. I mean, we don't have exact details for why some people develop it and others don't. We believe that some of this is genetic, but so the same reason. So a little bit of an aside is the idea that I've had patients come and say, well, my neighbor took chemo and died the next day, and I said, no, that's just time out. First of all, you don't know what type of cancer your patient had. You don't know his stage. Do not make that assumption. So
Yeah, I think a lot of times we know that there's definitely some risk factors related, but a lot of times we want to come up with reasons why something might be okay to do or acceptable. Sometimes you'll Google search something and say, well, this didn't happen that way, so it's really not that bad. But there is some reality to it. And we do know the bad effects. We do know the risk factors for it. Some people got lucky and they made it through their lives smoking without getting lung cancer, but it doesn't make me go out and tell them, oh, it's okay for you to smoke.
Well, radon is in the house, but she also talked about some of the chemicals and things that we're exposed to in the house.
So all of those, I would follow the safety recommendations on the back of them, right? But the EPA and the FDA do look out and regulate those things. And so you shouldn't have that type of exposure to those toxins. The best thing to do is if you do or you have a concern, go back and have a conversation with your primary care doctor.
And I would say also that it's two issues that we're dealing with. When you talk about those chemicals, we're talking about lung health, lung disease, and lung cancer. Those are two different things. Now, some of those things with exposures, depending on your medical history, your respiratory history, you push you at a higher risk, and you have aspiration, and you do absorb some more in detail respiratory problems. But those people with those respiratory problems also are a higher risk of lung cancers because it weakens the lungs, so it makes them more susceptible to disease.
Thank you. Yes, there's a question back here. We'll come to you next.
Real quick, panel, I got two questions. First question, secondhand smoke, thirdhand smoke you mentioned. What's the percentage rate as a toddler growing up that he would develop lung cancer? That's my first question. Second question, y'all mentioned clinical trial all the time. I know a person got CTCL, which is a rare blood cancer. Don't see too much clinical trial on that. How do we research and find clinical trial on that?
Is that first question?
First question is, like, is there a way to quantitate the exposure and risk of getting a disease when you're talking about second, tertiary? So think about like the individual who's the wait staff in a restaurant where someone is smoking, who's getting exposed to that secondhand smoke. Are we seeing an increased risk of these people getting lung cancer? And then the second thing is, what about clinical trials for some of the, what they call it sometimes orphan diseases, where you have such a small number of people? But how do you find out about information other than going to the Amgen site and seeing what trials that they have? How do you find out about getting the trials? Who wants to start?
So first, for the exposures, Vanessa, it really is hard to quantitate. I think the best thing is to probably, I keep going back to, your primary care physician, whatever else, because everybody's exposure may be different, whether you're working in an environment or there's, an aunt or uncle that comes and smokes or a family member that stays in the house or outside. It's hard to quantitate. We do know there's increased risk for developing lung cancer. However, it doesn't mean everybody will get lung cancer per se. There's other bad effects of it, and like we call the respiratory diseases, the asthma, the allergies that you see, the ear infections with younger kids you see. And there's several more reasons not to smoke outside of just lung cancer, but across the board. And then again, these other factors that you might be exposed to as well, the environmental, the pollution, the areas that you live in. Your ozone layer levels here are almost 12 times the rest of the state. So it's all of these factors that you have to look at.
What about the clinical trial?
yes, with regard to clinical trials, we have quite a vast number of clinical trials at my center. A lot of lung cancer trials, prostate, breast, and then for the rare malignancies, always good idea to talk to your physician, your primary care, or your an oncologist. Clinicaltrials.gov is a website that has all retinue of trials that are available. They may not be available locally, but within places like Emory or Vanderbilt, other places. So I strongly believe that clinical trials, they are the best treatment for our patients. And as Dr. Flano said, we know about Tuskegee, we know about all those bad things from the past, but things are much vastly better now. You're going to get either standard of care or standard of care plus something else. And that's how we're going to move the survival.
What was that website again when you mentioned about
clinicaltrials.gov? It's
at clinicaltrials.gov.
Yeah.
Okay. Ms. Beth.
And if I could say one thing, you asked a question about the toddlers and what's the likelihood of them developing. We are products of our environment, whether it's toddlers, whether it's adults, whether it's adolescents. We mimic the environments that we put ourselves in. So if your children, everyone knows that children can't wait to be adults, and all children want to be grown. But if your children see you smoke, when they're pretending to be adults, that's what they think is cool in adulting is smoking. When your children see you drink, when your children see you how you treat each other, that's what they mimic in behaviors, and smoking is not an exception to that.
And I want to make one other point. I think here in Tennessee, you ought to be aware that your attorney general joined with 24 other attorney generals in the United States in trying to stop the EPA from instituting a policy to decrease the percent of particles 2.5 microns and under from being released in the air. Why is that important? Because we know that particles that are 2.5 micron size get into the lungs, get into the bloodstream, and are known to be associated with cancers, lung, and a few other respiratory problems. So that is one thing that the EPA thinks that we could probably decrease the incidence of lung cancer and decrease healthcare costs by a couple of $1 billion a year. The second thing is, when you look at institutions that are trying to get rid of smoking in certain businesses and look at how your politicians are voting on those things, we have to get, if I may, I think one of the things that Mathis was alluding to, politically active so that if our politicians are not acting in our best interest, it is our best interest to vote them out. So we have to be very, very conscious of the things that they're doing. Those are some of the things we do. Yes, ma'am. Now you can stand up. Thank you very much for waiting.
Okay, I'm somewhat familiar with asbestos and how it travels. Radon, how do you identify radon?
Good.
There you go. How do you identify?
So radon, you can get the test. You can go online and get the test. And some of the like Home Depot, some of those stores, they will actually sell it. Okay, but it's a little test. You put it on top of your fridge. You close all the doors, stuff like that. Come back 24 hours later, package up and send it off. They're really cheap. And there's some. I'll look it up, and by the end of it, I'll have there's some sites you can actually order for free. But it just measures it because you can't see it, you can't taste it, you can't smell it. It's there. But if you can also find out, you should be able to go online to the Environmental Protection Agency and see what the levels are like in your area and get it tested, right? I'm pretty sure that there's some tracking. We find that there's trends where the areas that have the highest levels are in areas where the housing is cheaper, where a lot of us live, because people know that, hey, that's not really good there. But like I said, here in Tennessee, of the tests that are done, about a quarter of them, 26% of them are above the EPA levels.
Okay,
What's safe?
I live in an area that has been known through the years as a dumping, was a dump.
Okay.
Question, is this found in the soil or is it just in products?
So radon comes up from the soil, okay? But you got to think that other landfills, other areas where there's pollutants, toxins, whatever else, are still going to pose an increased risk.
Okay.
And I was tracking some of your numbers. This area is in the rate of lung cancer, especially in Shelby County, means that you guys probably, somebody knows or knows somebody that knows somebody that's had lung cancer that's developed. But then we heard about it here.
That's it.
So it's something to look at here. We were in Alabama, and the church was built on a mine.
Built on the Birmingham.
Birmingham, yeah.
Built on the mine.
And they had a hive. So when you start to see things like, well, this person has lung cancer, they never smoked, and this other person did too in the neighborhood, right? Or they might have had kidney cancer, or colon cancer. You start looking at a lot of these things and putting things together, because a lot of these trends that we know about us, we need to start thinking a little bit differently about that. When we start seeing younger people that smoke less but have higher death rates and higher risk, there's something about us we need to pay attention to.
Question number 2. You talk about tobacco. What about these vapors?
That's his favorite subject. Thank you.
Yeah. See, they only gave me a limited amount of time. A lot of times I give this talk for, especially in some of the high schools, I really harp on the vaping. It is, first of all, it was put out there to say, well, if you use these vaping, it's, you do the vape cigarettes, the e-cigarettes, it helps you quit. It doesn't help you quit. The little jewel packets, you buy one of those jewel packets, the nicotine equivalent of a whole pack. And people go through 2 or 3 of those in a day, right? And what's happening is there, again, it's that nicotine addiction that's being driven to keep you going back. But then eventually you're going to say this is too expensive, because that's what the kids do as well. And so, and Juul, this company knows that. And Tennessee has money coming to them because of their advertising and pushing it in this fashion, especially for the younger population, the kids. And I think over the next 6 years, Tennessee's supposed to receive about $13 million from them as part of the law settlement. Now, where does that money go?
Okay.
That's something that we as a community also have to think about when we start looking at voting and who we're putting in office and what they're advocating for, right? Because I got all your numbers. So here in Tennessee, off of, even they tax tobacco, right? They tax cigarettes. They get about $403 million a year from tobacco tax. The state puts in $2.6 million towards quitting and prevention. It's only a small fraction. The government gives another 1.6. They're almost matching them for that standpoint. So where's the rest of that money going? Because it's not going towards the $2.3 billion a year spent on diseases and hospitalizations related to tobacco use. So this is where we need to bring this to attention, and that's where we need to vote.
Thank you very much for your question. Yes, ma'am, please.
Yes, my name is Gwen Payne, and I had stopped smoking. Then all of a sudden, being a bit of, I picked it back up. So I had been going to the doctor, and he kept saying my white cells was too high, and they started screening me for cancer. They were screening me and saying that I might have cancer in my blood cells. Then they checked my lungs and everything, give me MRs, and everything. And they couldn't find anything. So I began to get sick, and they had to give me a pacemaker because I couldn't breathe real good. One night it's like I was out of here. But praising God, but I know we have to take care of ourselves. God will take care of us, but we got to have some kind of sense. So just lately, I just got out the hospital. I had a colonoscopy, but when I got out, I began to have seizures. I have seizures. And they didn't know what was going on. My white cells jumped down low into the teens, and they couldn't understand. They said, "You've been smoking." He said, "Since you stopped smoking these 5 days, you've been in the hospital. Everything started to go line up." He said, "Ma'am, that should tell you something." He said, "You need to leave those cigarettes alone." Now, my pastor, I always know what's going on with the sheep. He called me. Said, "I need to talk to you." And I said, "I already know what you need to talk to me about." Yeah. But I thank God for my doctors that they sit down and talk to me. I just feel like if you can't go to a doctor and they sit down and talk to you and listen to what you say, And like you were saying, they be able to tell you, and you tell them what's the little bit of things that's going on with you. And so they began to give me all them tests and screening, putting the pacemakers. I have one right now. But I've been off cigarettes 5 days.
Well, thank you very much for sharing.
Thank you.
Thank you for sharing. So,
I ask God to give me some strength because I know them cigarettes going to kill me if I don't.
again, thank you very much. Thank you very, very much for that. Let's take that question and throw it to the panel. So her point is very interesting. If you stop smoking, will you start seeing reversal of some of the damage, and does that decrease some of our risk for cancer?
So, especially as it relates to the lung, as everybody ages, your body and lung function starts to go down at a specific trajectory, right? You know, you start losing some lung function, it goes down. When you start smoking, rather than taking this slope, it takes a deeper slope. When you stop, you may not get those lung cells back, but then you go back to that original trajectory. It's just that you've lost some distance there. So you'll feel a little bit better, about 10% better, because that active injury is stopping. That chronic injury is still there, but you'll stop the decline from going as fast. And it's with all the other diseases that are related to tobacco use. But your story is really impressive, and I'm glad to hear it, and I think everybody else is glad to hear it. But the people that need to hear it are the young people that need to hear it. Because all of them that start, I've never had a smokers come in and say, oh, you know, I started smoking because I wanted to get older and have, you know, lung disease or heart disease or lung cancer, whatever else. They did it because I was out drinking with friends, I was doing this, whatever else. I just did it to relax. I can quit any time, and they couldn't.
Well, while you're thinking, I want panel members to think about your take-home point that you want all of us to have. But I want to ask you a question, Ms. Mathis, after Dr. Obeidi has it.
Just the comment from the audience is something that we deal with not infrequently in clinic. Patients get referred to us with high white count. And of course, as a cancer doctor, I'm wondering about, you know, leukemias and things, but I take the history and begin to unfold that, you know, there's a smoking history, and the two top reasons for a benign increase in white count are smoking and obesity. So, and when patients do quit, in about 12 months, 14 months, their white count normally normalize. So that's something that we see all the time.
I want to remind everyone to fill out your surveys. The second part of it, you filled out the pre-program evaluation. Remind you to fill out the post. At the end of the program, there'll be time for more questions. The speakers will be around, so you can come up and ask them then at the end. And also, there'll be representatives from Amgen who will be available to talk to you also. And I do encourage you. I don't think you all realize you got a multi-billion dollar company that has come to our house to talk to us. And let's take advantage of that. So let us end up with this. I want to know, what is the take-home point that you want us to have? I guess I should start calling you Pastor Mathis, but we'll have you started off. What is the take-home point? Then we'll go to Dr. Obeidi, then we'll end up with Dr. Flannel.
My take-home point, I guess, would be self-advocacy. We have to meet ourselves where we are, ask questions, be an active role in your healthcare journeys. When you have providers that you feel that you can't talk to, find another provider, find someone that can relate to you and speak to you in terms that you can understand, participate, if not even participate, learn more about clinical trials and make informed decisions about your health.
I mean, I echo those sentiments, you know, exactly. So the first point, I have 3 points. The first point would be to be an advocate for yourself. At the end of the day, this is your health. This is something that affects you. So be an advocate, you know, do your research, you know, talk to people, and also advocate for your family and friends. I mean, what you've heard today, don't just keep it to yourself. Talk to people. I mean, I wish the audience was larger today, but I know that hopefully we're going to go back and talk to our loved ones and our friends about what we heard today. So the second thing is, for those who are candidates for screening, please get screened. Please get screened. As Dr. Feno said, I am a cancer doctor, but I would happily go and do some other job if we find a cure for cancer tomorrow. I mean, it's a scourge on humanity. So the third thing is participate in trials. Please, let's improve our clinical trial participation rate and not keep accepting the fact that, okay, well, this drug was approved, but only 1% of the participants were African American. So basically, you're accepting a drug that may not really be representative of what would work for you. But so those are my 3 points.
That was a good one. I'd probably say if there's one thing is probably you gotta look at the opportunities that you have and take advantage of them. A lot of times we don't really define which direction we're going, right? If you want to, you make plans for which direction we're going to take our lives. It's the comment though, if you want to make God laugh, tell him your plans, but you can take the opportunities that he provides for you, right? And you have opportunities in changing your health, changing others' health. Opportunities where you have a company here which come here that's going to put forth information and opportunities that'll help our population. So if you pick the right opportunities and take those, then you can make a change. So I would say look at the opportunities you have, figure out what's going to be beneficial, and take them.
Let's give a hand to our panel. Pastor Gillespie, I want to thank you for hosting this what I think has been a most interesting discussion, and thank not only you, but also the Pearly Gate Baptist Church for opening things up. Thank you very much. As I am wont to do, sir, I want to remind everyone that there is a lunch that will be available. As I said, our speakers and representatives from Amgen will be available, and the only thing standing between us and lunch is Pastor Gillespie and his closing.
And the old folks said, let every redeemed heart say amen. I have really been enlightened today. It's been a great day for me, some things that I learned. And when they was talking about the random, I think they were saying things not make you want to go home and check my house and then get some. But I pray that everyone that's here today, even Apostle Brookins came with his church, I pray that we take what we have learned today and share it with others. Although I was looking at the live streaming for those that was on with us, and this is very helpful information. And now you all won't get angry at me when I be talking about quit smoking. Because you had these doctors and these professors that came out and shared with you the danger of smoking. Amen? And thank you, Mother. That's one of my members that got up and said that what happened to her, God had put on my heart to let her know that what you've been doing when God have taken something from you, you can't go back and do it. You got to let it go. Amen? My granddaddy said this, and I'm going to do this, and then I'm going to do the question. I want to thank my good friend, Stan Watson. Him and I, God have blessed him tremendously. And he's in Georgia, and him and I went through school together. But he already had set me up for the keyhole when I first came in. They asked me, doctor, and said, well, we was looking for you. Stan shared with us that how all your life when you came into the world, how you was always dressing. And he looked at me like that. I said, yeah. But I thank God that I have a classmate that God have blessed him and have taken him to this level. Thank the panel for coming and sharing. You all have really been helpful. Amen. My granddaddy said this to me, and I'm going to do this. He said, never make him glad twice. Glad to see you get up and glad to see you sit down. So I wanted to say, for those of you that have the questionnaires that they're asking you to fill out, be sure, because it's helpful to this organization. Take your time and fill it out and be sure to turn it back in to those who we need to give it back to. We're going to bless the food. We have food downstairs. Share with us. And then that way you can still ask them some questions, while we're downstairs. Amen? All minds are clear? Father God, we come now. We thank you for this day. What a beautiful day. What a wonderful day. We thank you, oh God, for the food that we're getting ready to share. Thank you for those, my members that came out and those that's working. Thank you for Frederick Durham, our IT tech, that helped us to make this what it is when it came to our PowerPoint presentations. Now we thank you, Lord, that give them safe traveling back home. In the mighty, mighty name of Jesus, we pray. And everybody said, amen. All right. It's good to see you. Thank you. Praise. All right.